Well, good morning. And thank you very much, Venki, for the great opportunity. And also for bringing us all together to this very special place, if a little bittersweet, in Ted Dietrich's universe. I'm sure it was December 1987, although I don't remember the exact date. I came across a flyer about some kind of a congress on laser applications in vascular surgery, and I found it intriguing. I thought about it for a while. I tried to dismiss it, and then I couldn't, kept going back to it. And I decided to attend, among other reasons, because I was familiar, somewhat familiar, with Dr. Edward Dietrich's name, mainly as a result of what happened on February 24th, 1983. This is from an actual AP news report of the first ever in history live TV operation. Happened to be a coronary artery bypass operation that, as most of you know, was broadcast on live TV in most of the United States, not in all states, but in some 35 states, and in the UK through the BBC. In the US was through PBS. So I knew a little bit about Dr. Dietrich and what he did. Ted's intent, of course, was to hold it here in the brand new, most expensive ever resort definition. Unfortunately, construction was delayed, as you can see on the bottom right of that slide, and it was not completed until the summer of that year, 1988. So we ended up at not a bad place, La Posada Hotel and Resort, which was really a wonderful place as well for the first Congress of many to come. This established, of course, a tradition of sorts, as you all know. The AHI Congress and Ted Dietrich, as you see him there during the live transmissions, became really the signature event worldwide of the early days of the emerging endovascular era. To me, and for me, it was completely life-changing. Not so much the lasers, that as it turned out, it wasn't all that important. But I went home, back to Baltimore, at the end of those 3 days, unforgettable 3 days, with two clear messages in my mind. One, that surgeons must learn and feel good about catheter endovascular skills, which we did not have at all, with very few exceptions. And number two, that we must do something about gaining access to, or even better, control of, imaging in our workshops if we want to join this new era that appeared to be the direction of things going at the time. And of course, our workshop was the operating room. So I came back. He allowed me to come back a few months later. This is the summer in Phoenix, working with him, and I repeated that a number of times that year, before the end of 1988. And by December 1988, we had managed to retrofit one of our operating rooms at MedStar Union Memorial Hospital in Baltimore and make it into this kind of AHI-like suite, not as good or as big, but with the same equipment, the ISS equipment that had been purpose-built and designed for this. Especially notorious was the so-called floating carbon fiber table that Ted designed together with Steve Hansen and a few others here in Phoenix, that was radiotranslucent and allowed one to do all kinds of imaging-guided procedures and also regular traditional surgery. So we established an endovascular unit. Ted actually came for that inaugural event in our hospital before the end of 1988, and we were off to the races. EBD, whose mother was a surgical nurse, and that probably had a lot to do with his future in life and in his profession, received medical training in Michigan, in Ann Arbor. He then trained as a cardiovascular and thoracic surgeon, as we know, at Baylor in Houston under Dr. Michael DeBakey, where he stayed beyond training for a number of years as an attending and a rapidly rising star. As somebody said, it was obvious to anyone looking that Dietrich was rapidly emerging as an extremely skilled surgeon and brilliant innovator. In 1971, to the surprise of many, particularly Houston, he left Texas and came here to Phoenix to found and establish the Arizona Heart Institute. And then a few years later, established the nation's first outpatient cardiac cath lab in 1979. That was pretty bold and remarkable. Ted, of course, famously invented the sternal saw as a young resident of 27, which became, as we all know, a standard tool for median sternotomy around the world. He really had set out as a resident to do something to open up the skull for neurosurgery, which was his original idea and aspiration. He realized that there was a grotesque way, as he called it in this paper that he published in 1994, narrating the whole experience, and thought that we could do better. So he set out to design a saw, only to find out shortly thereafter that Sears and Roebuck had already done it. They had the oscillating saber saw that could cut through any bone. Only he had to add, of course, some protective mechanism to protect the dura and the underlying brain from the saw. And that didn't take too long to create a device that unfortunately did not work very well. So then he thought, there's something else grotesque, and that's how surgeons open up the chest to get to the heart with a Levshy knife. Why not try it there? So they tried it on animals first, and it worked perfectly, protecting the heart and producing an excellent result. Shortly thereafter, they tried it on human beings. In those days, it was a little bit easier regulatory-wise to do things like that, as we know. The device was named the sternal saw and was described in full in the July 1963 issue of the journal Surgery. It was marketed by Sarnes, Inc., which was Ted's first company, 5 more to follow years later. Now, Ted's insight and genius led to another first, as you already saw, and now the development and installation of ceiling-mounted angiographic equipment in the operating room and a special table. So he was really instrumental, as we think about it today, in the early development of what we now call the hybrid suite that every good hospital across the land has, many years before the term was even coined. He was a complex, multifaceted man, no doubt. A musician and a sportsman, inventor, entrepreneur, film producer, and media personality, among others. But even more importantly, in my way of thinking, he was a dog lover. I think that is really very telling, perhaps most telling. I feel incredibly fortunate to have had the opportunity to intersect with such a man, truly one of a kind, irreplaceable, unforgettable. And I like to think of him like this. It's sort of like gravity. Once you are within its reach, it is totally inescapable. You just can't get away. So how did we get into this endovascular era that we keep talking about and living and working in it at the present time? Well, one could argue that it all started nearly 100 years ago with Forsman in Germany with this daring, risky self-experiment of using a urethral catheter that he stuck into the left antecubital vein and pushed it all the way in. The catheter was 65 cm in length until he could go no longer. He then walked to the Department of Radiology to look at it on fluoroscopy and saw and figured that the tip of the catheter must be in the right atrium, and it was, but he couldn't go any further. Apparently he wanted to go further than that. Well, he was fired as a result of that, and he switched as a result of that from cardiology to urology. Many years later, young radiology resident in Sweden, Sven Seldinger, suffered what he said it was a severe attack of common sense when he realized what was the proper optimal sequence of needle and catheter and wire in and out for vascular access, and published on a technique in 53, although he first presented it in 52, that we continue to use today. It was enormously important, advancing the future of angiography and endovascular intervention in every way that you can think of. Sones, of course, in the Cleveland Clinic, accidentally and serendipitously, as so many things that are of importance, discovered that a selective injection into the right coronary artery would not cause fatal fibrillation and death, but it would produce excellent images. And the rest is history. Having said that, Charles Dotter was undoubtedly the father of interventional therapy. Early in 1963, and somehow, I don't think too many people know this for some reason, in a most unplanned and accidental way, he realized the potential of catheters while doing a diagnostic angiogram for the renal arteries. The catheter went through a totally occluded iliac artery, almost inadvertently, but not to Dotter. His mind was prepared to understand the potential of what he saw. He then presented this at a meeting in Prague, part of Czechoslovakia in those days, of course, June 1963, where he had been invited by his friend and future associate in Portland, Joseph Roche. And Roche, many years later, described his presentation in that session that he attended, of course. And he said it was like a bomb had been dropped. And here's the bomb. When he said the angiographic catheter can be more than a tool for passive means for diagnostic observation. Used with imagination, it can become an important surgical instrument. Nobody ever had thought of that or said that before. June 1963. So that was arguably the beginning of it all. On January 16, 1964, Dotter, with Melvin Judkins at his side, performed the first intentional PTA case on an 82-year-old woman that you see there on that picture with a focal, tight, very symptomatic stenosis of the SFA. The procedure was quite successful. He used coaxial catheter system that we are all aware of. I don't want to belabor that too much. And then in 1964, narrating and reporting on 15 interventions on 9 patients, they published a now classic paper that signaled the true beginning of interventional radiology. Very famous paper. This brand new specialty was to become one of the most dynamic and innovation-driven disciplines in all of medicine, as we know. A critical intersection occurred a little before that, in 1963, at the meeting of the RSNA in Chicago, where he came across somebody named Bill Cook, who was showing some things on a table that appealed to Dotter. So they talked for hours, they liked each other, and eventually Cook agreed to beginning manufacturing and helping him design catheters for Dotter's ideas and Dotter's procedures, and that's how the Dotter dilatation kit came together, consisting of 2 8 French and 12 French Teflon catheters. Bill Cook, of course, the would-be founder of Cook Inc. and Cook Medical later on. The situation in the United States was such that Dotter, being brash and a little too aggressive, was never well received by the surgeons. And that kind of impeded, to some extent, progress with PTA. In Europe, it was a little bit different. The political situation was different. Radiologists have a greater say as to who was doing what to whom. Particularly, this German radiology, Zeitler, who was very interested in Dotter's ideas and procedures. He traveled to Portland several times, and then developed his own rapidly growing experience that was published a few years later. On May the 1st, 1969, a young Andreas Grunzig, aged 29 at the time, started working in this clinic in Darmstadt. He had had a brilliant medical career and had trained actually in 3 different disciplines post-medical school. It is well documented that it was this year and at this clinic in 1969 that he performed his initial peripheral angiography. This is what he looked like in 1969. He had come to admire Robert Hegelin because he was the author of a well-known textbook that he had used as a student in medical school, and thought that maybe the way to go for him and to advance his future and his profession was to move to Zurich. Well, he got an interview and he got a job offer and moved to Zurich to work at that clinic and university hospital before the end of that year. Tragically, Hegelin died only 3 weeks later of a ruptured AAA. He set out to develop a catheter with a fixed diameter, non-compliant balloon, which he figured was really the way to go. He liked PTA, he was doing PTA, but he didn't think of it as the solution or the better way to open up stenosed and occluded arteries. The early efforts were painfully slow and difficult. He had no support from anybody in Switzerland or anywhere else. So most of the work and the catheter construction activity, believe it or not, many of you know it, of course, happened on his kitchen table, literally. And this woman, Maria Schlumpf, his research assistant, was critically important in these efforts, as was his wife, Michaela. And Maria's husband, who was an engineer. So all 4 of them were working on this during off hours and on weekends. That picture you see there is the very first balloon they managed to construct. Not ready for prime time, obviously, but that was the first one. You had to start somewhere. February 12, 1974, success. First time use of a new single lumen homemade catheter with a 4 millimeter balloon, adequate for SFA angioplasty. And then a couple of months later, March the 6th, 1974, same with a larger balloon that you see on the right, the actual balloon that was used for the first iliac balloon angioplasty. Several more balloons and designs follow, again, relatively slowly and very difficult, still all homemade. The next critical intersection occurred in 1974 when he came across Heinrich Hopf, an emeritus professor of chemistry and a renowned PVC expert who pushed for Grunzig and team to use PVC instead of the materials they were using that were clearly inadequate. This proved really a total breakthrough because now there was no longer a need for an outer constraining mesh on the balloon, decreasing the profile and making things all a lot better. They did make an error, retrospectively, we can say, that they published on this and the first 15 patients being treated with such a PVC balloon, but only in the German language, as you can see there, for some reason which I'm not aware what it was. So this probably delayed dissemination outside of Germany and the German world for a good 6 months to a year. But it did get through. One figure that is not frequently enough mentioned was a cardiac surgeon in Zurich, the chief of cardiac surgery, a renowned, very innovative cardiac surgeon, a Swedish man, Ake Senning, who was there. They were good friends with Grunzig, and he was extremely supportive, even early on, of Grunzig's efforts with balloon angioplasty and trying to develop PTCA. So this was instrumental in Grunzig's being able to create smaller balloons for the coronary arteries, which finally managed to do by September 1975. And eventually, he was able to secure, finally, several research funding grants from the Swiss National Science Foundation, because until then he had no support economically or otherwise whatsoever. And most in the medical community were against him and antagonizing him, in fact. Another critical intersection, in fact, multiple intersections, but one in particularly, occurred in November of 1976 in Miami at the American Heart meeting. Granzig's presence there had a lot to do with John Abels, co-founder of Boston Scientific, to be there. As many of you know, John was always in the know, and he somehow managed to get Granzig invited to present during the poster session, and many people were intrigued, but one in particular, a San Francisco cardiologist, Richard Myler, who was to become a critical component of all of these developments from this point on. So they began to kind of commute between Switzerland and San Francisco, and they were very much responsible for all of the developments that followed from that point on. Granzig's first successful coronary angioplasty procedure done on a conscious patient in the cath lab at Zurich University Hospital was September 16th, 1977, as we know, on a patient age 38, same age as Granzig, by the way, 38. And this is very well documented to have had an excellent long-term result lasting more than 20 years without restenosis and documented by angiography. In fact, going back to Ake Senning, the chief of cardiac surgery, serendipity, really strikes again like it does so many times. He had moved to Zurich in 1961 from Sweden. He was Swedish, and became the professor of surgery and director of the clinic and chief of cardiac surgery. It was instrumental in Granzig being able to do even the first BTCA, not just development of the catheter, because everyone wanted to get in the way, antagonize him, and said, this is an experiment, you're going to kill a patient, there's no way you can do this. He stepped up, this cardiac surgeon, and said, listen, I'll step in, I'll stand by, something happens, I'll fix it. And that's the only way he managed to do it. So that was extremely important. Granzig, of course, is legendary for his focus on education and the dissemination of information. He started, among other things, live demonstrations, talking about that, with Ted Dietrich. There you have some pictures of the famous amphitheater at the Zurich Hospital, where we were, by the way, with some of you who are present here today, at the Granzig Society meeting in Zurich in 2007 to celebrate the 30th year anniversary of that first procedure. We were in that place that you see there on the photo. He also pioneered the use of laser pointers. I don't know if you know this. He was very careful, unlike Daughter, he wasn't brash, he was accommodating. Everybody sort of liked him, surgeons included, even in the United States. Can you imagine that? If you really look at that picture, you can see that his left hand, and especially his left index fingers, is on the hole at the end of the laser, because he was aware of the risk of pointing a laser on somebody's eye and what damage that can cause. So he was always worried about that. A few months later, he confessed that he had to stop using the laser because everybody was so interested in looking at the laser and wondering what the hell that was, that nobody would pay attention to what he was saying. So he decided to not use it anymore. But it was he who started with that. In 1980, as we know, he moved to the United States, to Emory, and that was a very interesting process that obviously I don't have the time to dissect out for you, but it is in a paper that was just published last week, and I'll show you that at the end. He obviously continued to do live demonstrations and these courses, only much bigger, in Atlanta at Emory. There you have, look at that picture on the upper left of the slide. I mean, that's crazy, right? A little too many people there. So this went on for a number of years. Everybody from all over the world wanted to come to see Granzig, to train with him, to work with him, to meet him, etc. And then tragedy struck. Sunday, October 29th, 1985, plane crash. He and his new young wife, Margaret Ann, age 29, a radiology resident, both killed instantly in a plane crash in his plane. Nobody knows to this day exactly what happened. But even more tragically, that same year, 1985, all these four giants died. Granzig, of course, Sones, Judkins, and Daughter, all of them gone. 1985, the worst year of endovascular and interventionalism. As we now know, transluminal recanalization and PTA has many limitations. And this was in fact recognized very early on. In fact, Daughter, in that famous classic paper of 1964, envisioned this and talked about it, and he envisioned the need to use a splint, or splints, he said, in order to support the artery during the healing phase and during what he called re-intimalization. Is what we now call stents. Again, himself, the following decade, the first paper, the first experimental work on percutaneous stents, nitinol coils, published in the Investigational Radiology Journal, 1969. Hans Wallsten was an outstanding Swedish inventor and entrepreneur who dedicated essentially himself fully until age 45 to the paper industry in Sweden, where he was from. He established his first company, Inventing, in the late 1960s to market and manage a rapidly growing portfolio of inventions. In '73, he moved to Lausanne, Switzerland, as he said, to create another development center, whatever the hell he meant by that. His entry into the medical field was totally by chance, serendipity again. A cardiology friend asked for his help to develop a device to prevent stenosis of some sort. This eventually led to the development of a wall stent design stainless steel meshwork tube that was self-expanding. He filed for patent in 1982, and then he founded his next company, MedInvent, to develop the brand new device, which was dubbed the wall stent, although he described it as an endoprothesis, which was a great term, a great word. The historical first coronary stent implant using this endoprothèse coronarienne was performed by cardiologist Jacques Poole with the help of Rousseau and Joffre, two radiologists, at Toulouse University Hospital in France. Ulrich Sigwart was meant to have done it first in Lausanne, Switzerland University Hospital, but there was some administrative screw-up of some sort, and he was furious about it, so he came in second, doing the same procedure in Switzerland a few months later. However, he was undoubtedly a brilliant innovator who played a pivotal role in the conception and early application of coronary stent technology. He also was the first to document stent-induced restenosis, both angiographically and histologically. As to the periphery, Hervé Rousseau, a French radiologist in Toulouse, was the first to implant the wall stent for iliac artery stenosis treatment. Cesare Gianturco, another very important name, was a true giant whose contributions cannot be overemphasized. He was born in Naples, the youngest of 8 children, a remarkable family of high achievers. Must have been a real challenge growing up there. He came to the US, to the Mayo Clinic specifically in 1930, to train as a surgeon because his older brother was a surgeon with a growing practice, and the idea was for him to train as a surgeon and go back and join his brother. But he unexpectedly, unfortunately, died while he was in the US, so he swerved from surgery to radiology. Over the course of many decades, he really, truly became a living legend in both general and interventional radiology. His Gianturco Z stent unfortunately, proved inadequate for coronary implantation. So a balloon expandable coil stent was designed working with Gary Rubin, an Australian who had come to Atlanta in order to train under and work with Grunzig. And Gary Rubin was very instrumental in these developments. He went on, as we all know, to become a renowned interventionalist, innovator, and medical entrepreneur. So they created a stent that was called the Gianturco Rubin Flex stent, first used on a patient at Emory University on September the 3rd, 1987. It was the first coronary artery implant in the US. It was granted FDA approval in June of 1993, again the first FDA approval for such a stent. It was used successfully in many cases, but eventually could not compete with other devices just around the corner because of a high incidence of restenosis. Julio Palmas, a man I know quite well, was born in La Plata, Argentina, the province of Buenos Aires, where he became an MD in 1971. He came to the US in 76 to pursue radiology at UC Davis. He is by far the most notorious stent pioneer, inventor of the balloon expandable stent. It is well documented that Palmas conceived his primordial initial ideas while listening to Grunzig at the SCVIR meeting in 1978 in New Orleans that was closed by Grunzig, talking about his technique of balloon angioplasty. And apparently he emphasized, perhaps overemphasized, the problems with balloon angioplasty. So Julio thought that maybe we ought to think of a mechanical solution, scaffolding of some sort. And he just couldn't stop thinking about it. Then they shared the taxi to the airport at the end with his boss, at Davis, Stuart Reuter, and told him, listen, I've been thinking about this, I'm just going crazy. The last few hours, I cannot stop thinking. What do you think about this, doing this and working on that? And he said nothing, but at the end, he was very receptive. He said, well, work on it, write it up, and send it to me. It took him a while to do so, but he eventually got around to it and sent it to him. And then he figured out, at least theoretically and conceptually, how it would work. The initial steps, the first couple of years, were painful in many ways. That's one of the first prototypes ever built by Palmas, literally in his garage, of the stent. Then a great opportunity presented itself in 1983. In fact, it was Reuter who told him about that opportunity because he wanted to go there and did go there as well, moving to the University of Texas Health Science Center in San Antonio, where they had an excellent lab and facilities, and they really wanted them there. And so they went, and this changed things for the better in a most significant way. Was there that he met Richard Schatz, who was a cardiologist at San Antonio's Brooke Army Medical Center. More importantly, through Schatz, they came across Phil Romano, an entrepreneur who founded restaurant chains such as Food Rockers and the Macaroni Grill. There you have a picture of the man who decided to invest $250,000. Nowadays, this would be equivalent to maybe $750,000, something like that. It was significant money and really took him to the next level. The trio called themselves the Expandable Graft Partnership. They patented the stent in 1988 and presented it to a variety of large companies. Several said no, most notably Cook and Boston Scientific. But J&J decided to license the Palmas stent technology for some $10 million, 25 to 30 million in today's dollars, plus royalties. But they really put their muscles and money behind it with an additional $100 million, about 300 million today, for its development. So the Palmas stent was approved for use in peripheral arteries in 1981 and coronaries in 1984. J&J quickly captured 90%. Some of us lived through that, but some of you are too young perhaps to know it or remember it. of the market for stents worldwide and bought the patent outright from Palma, Schatz, and Romano in 1998. Schatz worked with Palmas to miniaturize a stent for coronary application, naturally. He proposed an interesting idea of using two short stent pieces, 7 millimeters each in length, joined by a 1 millimeter bridge in order to reduce stiffness and, more importantly, make it more flexible and more deliverable, which was a big problem with the iliac Palma stent for a vascular bed like the coronary arteries. The stents were first crimped using a special tool and later placed manually on a balloon sized to the target coronary artery. Of course, they were not alone. This never happens in isolation. There were several other important groups working on things like this, including Darter's important ideas that I already mentioned. Krag and Platz et al. Also had a paper out at the same time on a similar technology, and Maas et al. Published their early work with self-expanding spiral stents about the same time. First human implant of the J&J Palmas iliac stent by Getz Richter, at the time at Freiburg University Hospital, in May of 1987. Julio was there working with him. The initial clinical report on 15 patients was published in '88, showing very promising results. The launch and completion of the US iliac stent trial was extremely important, a real benchmark, and led to the FDA approval in 1991, the first vascular stent to be cleared for commercialization. The J&J Palma Schatz coronary stent was first implanted on a human patient December 10, 1987, by Jose Sousa in Sao Paulo, working with Richard Schatz and Julio Palmas. And it was finally granted FDA approval August of 1984. Within 4 years of FDA approval, the balloon expandable stent was being used in more than 80% of coronary interventions. Unthinkable. But it wasn't going to last. Today, the Palma stent is on display at the Smithsonian's National Museum of American History in Washington, D.C. The combined Palmas and Palma Schatz inventions are widely considered to be among the top 10 medical devices of the last 50 years, used in 100+ million people worldwide. Unbelievable. Julio and his family today live mostly in Napa, although they have homes in other parts of this country and other countries, most notably Punta del Este, Uruguay, where his wife prefers to be, Amalia, a very nice lady. They have built this incredible vineyard and winery. I know my time's up and I'm almost at the end here. Sorry to go over for a minute or two, but I think they are engaged, so let's go on for a minute. An incredible place. The whole thing is the most high-tech place you can ever imagine, all built underground, under a hill. Can't even imagine how much that must have cost. And so it goes the saying, how do you make a small fortune in the wine business? How? You start with a big one. And certainly that was true for Julio, wasn't it? So I'm not going to have time to tell you about this dentist, but that's why stents are called stents. A Dutch surgeon, Johannes Esser, had a lot to do with the translation between that and the medical surgical world when he started using that material, that compound, to stabilize wounds, facial wounds. You know, during the First World War, which was, of course, trench warfare, there was an epidemic incidence of severe facial wounds. And that picture there gives you a sense of why that is, because they were picking over there to look and to shoot, and they were hit on the face, and some of them survived, unfortunately, with a totally destroyed face. So it was epidemic. And this really was the beginning of plastic surgery. That was the beginning, World War I. So it was this surgeon who started the use, and then eventually he found utilization in other walks of surgery. Stents, I like to say, became inevitable because of the way angioplasty works, which we didn't know at the beginning, of course. everybody, Granzig included, thought that he would just compress and push the plaque and the atheroma into the wall, and it would stay there in some cases, etc. And you know that's not what happens at all. What happens is what you see there, which is ugly. We live an incredibly chaotic scene within the artery after the balloon is deflated, so it's little wonder that problems occur. In fact, I wonder why the hell it works at all. And it does work, we know, in many cases. But scaffolding was inevitable. And stents really became the most important development because they served unbeknown or really unthought of at the time, the winning platform for a number of technologies that we're talking about here yesterday and today that we are all aware of. So there is a list, a condensed list of angioplasty history first and stent history first. And here we are in a totally different environment. We have transformed ourselves as surgeons, particularly vascular surgeries, as all-around vascular specialists. As I said before, this publication appeared in the Annals of Vascular Surgery last week, online with lots more details than I've had time to discuss with you today. And I thank you very much.